Hello, everyone. This is Zach Ford with AIDS United Sector Transformation Program. Thank you for joining us today for the third webinar in our monetization series. This webinar will focus on establishing effective contracts with payers. The webinar will last approximately 1 hour, and it will include time for question and answer at the end. Today's slides and a recording of the webinar will be available on the AIDS United website. As a reminder, this webinar is being recorded and participants are in listen-only mode. You can listen by calling 1-866-740-1260 and use access code 876-2819 or by enabling the audio in ReadyTalk to listen over your computer speakers. Please use the chat function in the bottom left corner to ask us a question. At AIDS United, our mission is to end the AIDS epidemic in the United States through strategic grant making, capacity building, policy, technical assistance, and formative research. At AIDS United, our mission is to end At AIDS United, we're a national nonprofit organization with a singular mission and focus to end AIDS in the United States. We lead the charge for responsive and effective federal, state, and local policies that benefit people living with and at risk for HIV. We invest in innovative models to meet the needs of communities affected by HIV and AIDS. We have given more than $104 million in direct funding and leveraged $117 million to increase capacity of communities and organizations responding to HIV in the United States. And we inform the field with best practices and lessons learned. We advance advocacy based on sound public policy, strategic grant making to affected communities, targeted and tailored capacity building for organizations responding to the epidemic, and research and evaluation to inform the field. We work within a social justice framework that challenges the foundational issues of racism, sexism, homophobia and transphobia, socioeconomic inequality, gender discrimination, and stigma. This webinar series will include free one-on-one coaching with the Minges Group on a first-come, first-served basis. Any HIV-focused community-based organization interested in individual coaching by the Minges Group regarding establishing and strengthening relationships with payer organizations should email myself and Paola Verona at st@aidsunited.org. With that, I will turn things over to the Minges Group.
Hey, this is Joel, Zach. Thanks. Can you hear me on my phone?
Yes, we can hear you, Joel.
Okay, I'm unmuted. My laptop has just crashed. So, Mo, I hate to do this to you, but if it's okay, if you could start, and then I'll let you know when I can kick back in. I'm really sorry. I have no screen in front of me at the moment.
Okay, no worries. Good afternoon, everyone. Thanks for joining us for our third webinar. Today, we will be discussing how HCBO should choose specific targeted services to include in a contract with a payer, document the value that you deliver, identify quality metrics to include in the contract, as well as establishing appropriate pricing and payment terms that both the HCBO and the payer can agree upon. All right, so targeted services. So some factors that you want to consider when deciding exactly what to offer a payer is what are your existing expertise and your capacity. So you don't want to be offering too much that you can't handle over the course of the contract. You also want to be sure to talk with the MCO to see what their various needs are. And so that's going to be the beginning of your discussion with the MCOs and see how you two can come to an agreed upon contract. You also want to be able to see what services Medicaid covers. So in order to be reimbursed, you want to be able to provide and render services that you'll be able to get paid for. And then lastly, you really want to be focusing on what the community's needs are. And this is something that HCBOs are very good at doing. You guys are really involved in the community and know what the community needs. So that's also another talking point that you can use with the MCO in order to figure out exactly what services to be providing. And so going into a little bit more detail with the different partnership opportunities. So MCOs need to compete effectively with other payers and are being required to demonstrate community ties. And so this is what I just said, that HCBOs are really embedded in the communities that they serve, and they really have a strong handle on the social context and the medical needs of their members. MCOs have a difficult time locating many of their members living with HIV, as well as many members who are high risk in other areas. And so this is another ideal place where an HCBO can serve as a liaison to help better MCO and member relationships, contacting the different members who the MCO has had a hard time reaching and getting them connected and getting the member access to the services that they haven't had. So a lot of ARV therapies, like many, a lot of ARV.
Mo, I can join in if you want, but keep going, and then I'll finish this bullet, and then I'll jump in. Sorry.
All right, no problem. So costly ARV therapies, like many of you guys know, are a really big challenge. And so MCOs serving people living with HIV are having a hard time keeping their members adhering to the medication regimen. And so this is another place that HCBOs can come in handy with monitoring their members' therapy adherence and making sure that the MCO isn't paying for medication that's not being utilized. Joel, you can take it from here.
Yeah, thanks a lot, Mo, and I'll probably lower the quality of the presentation. I really appreciate that, Mo, and sorry about my IT issues. Yeah, on the drug front, one thing that's going to work in everyone's favor soon is patent expirations of the antiretroviral medications are going to continue to occur, and as that happens, the price, the pricing of this that has been a real problem for everyone, I think, is going to become less of an issue as generics come in and make this far more affordable. But at this point, it's awkward for MCOs to, if someone's not symptomatic in any meaningful way and they are infected, it's awkward for the health plan to really want to pay over $20,000 a year for someone who isn't symptomatic, and at the same time, this is a death sentence condition without the meds, and so it creates tensions about when to introduce and how to best introduce and deal with these pretty obnoxious pricing. That's going to wither away, and I think we're going to be able to get these meds to people over time much more cost effectively, and the plans are going to be much earlier allies. The health plans are going to be much earlier allies in the therapy than they've felt is affordable to them for people who are not symptomatic. MCOs do have their own care coordination staff, and so a lot of what the HIV CBOs are bringing to the table is reaching out, doing outreach and coordination of services and linkage to housing and so forth. A lot of health plans, particularly in the Medicaid arena, are going to say, well, we do have people who do that, and that's going to create some boundary line issues. Some of those staff may feel encroached upon if the health plan contracts with a CBO to do very similar things. But, what you guys know and do with the HIV population is unique and super valuable, and it's going to need to be worked out. But you're not walking into a health plan environment where they don't do any of this at all typically, and you're going to have to plug in and fill their gaps, with them and for them as you contract with them. But as Mo said, couple bullets above and on the previous slide, there are health plans do have a heck of a time locating a lot of their members, and so, and particularly with HIV, and often sort of drug addiction that led someone into HIV doesn't go away. That addiction didn't go away when they contracted HIV, and there's still a lot of homelessness and transience and legal issues and so forth. But you guys are, far better positioned to just find and support that particular kind of subgroup than the staff the health plans probably have on board. And so there's an opportunity for you guys there, although there is stuff to navigate with who they already have. You guys are embedded in going to the right side bullets. You guys are embedded in the communities in a stronger way. The entities we've worked with are just profoundly in the communities you guys serve, and the health plans try to get there, but I don't think they're as able to be as close to the member population, your kind of client population as you guys get. That's why you exist. That's the value you provide. So I think there's an opportunity for you guys to take them where they need to go to serve these folks, optimally, which is get face to face with them much more often than the health plans are able to. The second bullet sort of follows on with that, but there's a big role for text messaging and computer algorithms and telephonic work and so forth, the things that the health plans are doing more and more of. But there is also a need to really know your care coordinator and the person who's digging in and helping you, and the HCBOs bring that to this population in a way that the health plans typically are not able to, and that creates a business and a partnership opportunity for you guys. The health plans have real-time pharmacy data, and you guys typically do not, but you do have, marrying yourselves in with their real-time data and your sort of feet on the street and level of relationship and contact with folks can really be a powerful team to help medication adherence occur in the second to last bullet on this slide. You can serve as an on-the-ground extension of their people that I think way ups their game, and at the at the level of what it for what it costs to just avoid an admission or two across the year, a health plan can come out ahead, drawing upon you guys pretty extensively if your work is preventing even a small handful of inpatient exacerbations that lead to high-end, high-cost care. On slide 13, example services to provide. A lot of this falls out of what we were just talking about on the prior slide, but identifying people who are not in care and trying to just sort out what their circumstances are. And I don't think it's in the MCO's interest to have ticking time bombs out there from a clinical and cost point of view, and enlisting your guys' help to just like I was saying earlier, find these people, locate them, and engage with them is tremendously helpful. From all fronts. It doesn't. Health plans, I think, often get somewhat of a bad rap that they just want to minimize their today costs and so forth. But it's very much, even if they were just financially oriented and they don't care at all about someone's health, which they do in fact typically care deeply about their members' health. But even if they didn't, and it was just a financial transaction for them, it's in their interest to connect with folks and engage with them rather than let them blow up into the hospital 4 times in every 18-month period. And so I think there's a huge amount of win-win opportunities, and we're working with we worked with for the HCBOs last year, and we're working with more on the one-on-ones already, and we look forward to more of that with you guys as the rest of the year plays out. But we're convinced that there are populations that the health plan has that there's just tremendous value in you guys plugging in, particularly around these first two bullets. Creating just getting visits scheduled both with yourselves and with the provider community, arranging transportation support, literally accompanying people to their appointments if need be, if there's resistance or reluctance to mistrust of the healthcare system, but trust of you guys. So that for some cases, I think a literal almost hand holding to care role is beneficial. And this is not we're not suggesting that this be done to everybody you touch, but there are specific members who can benefit from this type of model particularly well. Medication adherence, we've talked about. Housing supports are, unfortunately, a major need for the clientele you guys serve. Not educating you by any means on that, but helping the health plan, helping someone get housed does wonders for the person's clinical, trajectory and cost trajectory. So again, there's a win-win opportunity with the health plans tapping into your acumen in getting persons with HIV housing supports. Psychosocial assessments, Medicaid eligibility is another. I don't think if there's in the 1980s, 1990s, there was sort of a feeling, well, health plans don't want to even enroll the HIV population. They cost, you're getting $200 a month premium, and you're getting a person with HIV who's going to cost you, $7,000 a month or whatever it is. It's just unwelcome enrollee for the health plan. That's not the case anymore. There's risk adjustments that pay a fair rate to the health plan that's adjusted for the conditions they serve. It's, at least in the Medicare and Medicaid program, which is a lot of where these partnerships that we're talking about exist. The health plans are being paid fairly and adequately for a person with HIV, as well as a person with cancer, or and, many other. The sophistication of the premium now is adjusted, so they're not getting a $200 average for everybody, no matter what their costs are. They're getting much more surgical premium rate at the front end. So it is in their interest to serve and retain their high need enrollees. So Medicaid eligibility assistance, both for the sake of the beneficiary to keep them covered and be able to keep track of whether they've fallen off the wagon with medication adherence and so forth, is super valuable to the individual and super valuable to the health plan, and an area of partnership opportunity for you guys. It doesn't help any of us anywhere in the system for these folks to just lapse into a loss of eligibility. So there's important work to do to just retain that. And Mo, you can remind me, since I lost my notes stuff when the thing went down. Are you coming in on this slide or on the next one?
I'm coming in on slide 16, so you can go through documenting your value.
Okay, so so I'll start. I'll keep going with 15. Thank you. So in terms, a key issue that we've heard from the beta test sites we worked with last year, and that's come around again, is the health plans don't see our value, or we're not confident even in how we can make the value proposition to them. And so a fair number of things that we've done over the past year and a half have kind of focused on demonstrating your value to the payer community. And next month's presentation, I think, is going to focus a lot on pilot testing at a small level and getting data that shows from the health plan on their folks, but that shows which people you think you're most likely to be able to help in a financial win-win for them, as well as a clinical win-win. But before even getting to that, just working with what you guys have, what are your, creating a compilation of your statistical accomplishments. One of the one-on-one clients, health entities that we're working with at this point, we're encouraging them to try to literally do a survey of their existing clientele, saying, before you came to us, how many admissions to the hospital, how many ED visits, et cetera, did you have in a year before you came to us? How many since coming with us? And trying to create sort of a before and after favorable impact through the survey mechanism, including issues also, if you want to delve into this, the amount of drug use before and since coming to you, alcohol use and so forth. If anything you think you might have made a dent in, try to get that into the survey within reason, and then look at what the survey data show. But you may have a lot of accomplishments that fall out of that survey process that wouldn't be too costly for you guys to put in place with your members, and could yield a lot of proof points in terms of, look what we're achieving with the people we're serving, that would be attractive to the payer community in terms of making them more interested in partnering with you. Short of statistics, or in addition to statistics, I should say, case studies can be super valuable. And I think, creating vignettes around, here's a person, in this slide we named him Stu, but here's a person when we got him, here's what the person's circumstances were, here's what we did to support this person, and now here's what this person looks like today, and here's maybe quotes about the person's own perspective of what his or her chances are going forward from now versus what they were. But there's a lot of powerful things that can be conveyed in a case study that personalize what you guys do in a compelling way. And I didn't mean to say in lieu of the statistical accomplishments. I think you need to try to get to both if you can. With that, I'll turn it back to Mo.
All right, so now I will be going over performance metrics that you guys can include in a potential contract with a payer. So one of the most important aspects of a contracted arrangement is the reliance on data and analytics. So costs and quality measures should be agreed upon by the HCBO and the payer, and then you both could use these metrics to incentivize everyone involved in the contract. And then we also encourage the HCBO and the payer to establish data sharing capabilities. And this could help you identify the initial population that you will create a pilot program around. And this will most likely be members living with HIV, but could also include any other high-risk population. And then these data points, which I'll go into more detail in just a second, can also be used to track performance throughout the contract. So we've listed a few performance metrics to incorporate in a value-based arrangement, which we'll get into more detail later on in the webinar. But these can include HIV viral load suppression, access and adherence to HIV antiretroviral therapy, HIV medical visit frequency follow-up after an ED visit for mental illness, follow-up after an ED visit for alcohol or other drug dependence, and then average hospitalizations and ED visits per person per year. And these are only a few metrics that we suggest. However, depending on the specific contract, these performance metrics can be expanded based on the services that you're providing. And so a lot of HCBOs that we've spoken to, particularly the 4 HCBOs that we had our first pilot around, they had a difficulty pricing out the services that they offered. And so to help guide them, the Menzies Group created a cost and pricing derivation worksheet, which I've hyperlinked and you can access following today's webinar. And so some of you have already seen this, but for those of you who haven't, I'm going to share my screen quickly and give an overview on how you can utilize this tool. So This worksheet was developed to assist HCBOs in establishing initial prices for their MCO contracting partnerships, as well as for assessing performance within these contracts. And so the first tab lists different staff positions and the monetary values associated with each. And we listed potential positions that you all might have within your organizations, but this column should reflect the positions that make sense to your actual contract with the payer. And then the cells highlighted in yellow should also be altered depending on your organization's financial structure. And so we've included these numbers just as dummy variables to kind of calculate all the costs. And so what we have are the annual salary, the benefits loading factor, and the organizational overhead loading factor. And then this created the fully loaded hourly rate. And then we've also included a column that shows your target profit margin. And so, as I said before, this is just going to be based on everyone's specific organization and what works best for you guys. And so as we click through, we have monthly services, and so we've calculated the initial assessment as well as ongoing case management. And then again, all of the yellow cells can be changed depending on how your contract is going and what services you guys are providing to the MCO. And we also provided an initial assessment workflow estimate, an individual care plan workflow estimate, and then a monthly case management workflow estimate. And so all of these tabs are pretty much just useful for your organizations to better organize yourselves when contracting with a payer, and just listing out and kind of getting the making it easier for you guys to think through what exactly you can offer the MCO, how many hours you guys are estimating to put into this. And then the last sheet gives you the revenue derivation, including profit margin as well as removing the profit margin. And we've calculated all of this based on the hourly rate derivation sheet. And so as you can see, we have, based on the number of enrollees you're going to be case managing or offering any other services to, you could see the total assessment fees and the total monthly case management fees, as well as the annual revenue, increases as you increase the number of enrollees that you're providing services to. And as I said before, this will be available later on after we upload the presentation.
And Mo, I'll just add, I mean, this is a spreadsheet. If the structure of this doesn't work for you, but it does get you 65% up the road towards how you can price your services effectively, then play with the spreadsheet to get it to where you need it to be. But we didn't have a way to make this fit everyone's everyone's circumstances, but hopefully it is a structure that can get you off the ground towards pricing your services for a payer responsibly, reflecting your own cost structure. There are going to be assumptions in here that you're going to have to live with and modify once you're in the contract and so forth. But our intent was to try to get some water into the desert, if you are in the desert, of just not having a path yet in terms of how to attach a price to what you do from a payer's point of view of what they would be relating and paying for.
Thanks for that addition, Joel. Okay, so moving forward, one pricing structure that's easy to implement is one where the payer would pay the HCBO a monthly fee based on a monthly fee for each assigned member that the HCBO is serving. And the monthly fee would be based on the rendered services and would be cost out using the derivation worksheet that I just went over, or any other method that you guys have to price out your services. And then HCBOs could also implement a financing structure that would allow for an easier transition toward higher levels of risk, such as a quality incentive or a value-based arrangement. And so we've included this APM framework figure from the Healthcare Payment Learning and Action Network, and it details the different payment categories an HCBO, or anyone for that matter, can implement in a contract. And so the first category is where the pricing structure that I described earlier, and so the payer would pay a monthly fee, and there wouldn't be any quality or value metrics linked to the arrangement. Category 2 starts to bring in different quality and administrative incentives into the contract arrangement, and this can be incentives linked to operations, performance metrics that I discussed earlier on in the webinar, and can also include penalties associated with those performance metrics. And as we move towards the right, category 3 is where some payments are linked to the effective management of a segment of the population or an episode of care. So payments are still triggered by the delivery of services, but there's now an opportunity for shared savings or a two-sided risk. And Joel, feel free to hop in at any moment to elaborate. And then we have category 4, which is a payment structure that's not directly triggered by service delivery. So in this case, payment is not linked to the volume of services. So you'd have both clinicians and payers, as well as the HCBO, being paid and responsible for the care of a member for a long period of time, which can begin as short as 1 year of health. And we've included an example of what a value-based mechanism could look like. So service fees could be discounted by, let's say, 10%, and the repayment of this amount would be contingent on successful achievement of hitting a specified metric. And these metrics could include anything from cost savings to quality. And if the HCBO exceeds any of these metrics, they could also receive a bonus compensation. And so in this example, we have the bonus structure mirroring the discounted rate. So a 20% discount would occur with a 20% bonus opportunity.
Yeah, and one thing we're seeing, political, state politician after state politician say is, I want to pay much more for value and much less for volume in my Medicaid program, and that's becoming, it's cycling through, and Medicare's got a lot of the same dynamics, and the commercial insurance arena as well, but the health plans are really looking for ways to not just entirely pay on a fee basis, just accommodate, although that's very fair in terms of paying for the volume and mix of what the receiver of that fee did, but the system's trying to move towards also paying for what was achieved, not just what services were rendered, but trying to pay bonuses and even extract, discounts or risk if what you're trying to do didn't pan out, and rewarding people when what they're doing did pan out. And so, we've put this slide in here to kind of accommodate the new wave of value-based payment that's sweeping through. And but I think this is an area where you guys can align effectively with with the payer community.
All right, and so that's it from us. So we would like to open up the floor for any questions or comments any of you might have. And so you could use a chat box to ask your question, and we'll answer them in the order that they come in. Sorry, Zach, I think I stole your line.
That's completely fine, Mo.
One thing I can just offer up randomly is that, Mo has taken some improv comedy classes in the past year, so hopefully that prepared him somewhat for getting 4 seconds notice that he was going to have to present some of my slides this afternoon. But one of your questions might be, how long will it be before Mo becomes violent towards me? But he's up to now he's tolerated a lot.
Yeah, you're lucky. And so while we're waiting on some questions to come in, I have on the screen some upcoming webinars in this series. So October 11th, we're going to be really getting into the weeds of actually creating a pilot program. So, taking everything that we've discussed so far and really trying to make it as applicable as possible and really get the ball rolling with creating a pilot program. And then November 15th, we have collaborative learning. And we've actually had a lot of HCBOs contacting us in regard to billing services and more of the administrative side, which makes complete sense, but that we never really thought of. And so we might be creating one of the webinars to reflect that interest. And then December 6th, we also have next steps. And in that series, we'll really just kind of have the hour for people to answer questions and really think through what you guys have learned and how you can start implementing this in the real world. And it looks like we have a question.
Yes, we do. Mo, if you want to read it and answer it, that will work.
All right, sounds good. So from Raphael, what kind of data systems are needed on the HCBO side for the Category 1 and Category 2 type of arrangement between the HCBO and the MCO?
Mo, do you want me to take a first shot?
Yeah, go for it.
Okay, so one reality is that the health plans, have access to much more powerful, expensive, sophisticated IT systems than the HCBOs have. But to a large degree, in these partnerships, you'll be relying extensively on, part of this partnership is bringing their data sophistication and resources to bear on the partnership and bringing your guys' touchy-feely, strengths to the partnership. But it is going to be necessary for you guys to be able to track all of the contacts that you're having, so that you can demonstrate that the degree to which you are doing what you do. So at minimum, there's going to need to be sort of a contact tracker of sorts that you guys have in place, and to the extent you can, I don't know what software each of you have at this point. I'm sure it's different, but there, a systematic repository of when you've reached somebody and when you've attempted to reach somebody and didn't, and what the gist of the conversations or the face-to-face interactions you have. Computerizing all that is super helpful to 365-day care coordination effort. Is one piece. It's also beneficial from the point of view of billing, in terms of being able to demonstrate the quantity of what you've done and to justify the monthly fee sort of structure you're getting. If you're getting a per person monthly fee, the health plan at some point is going to want to see some documentation of what they're getting for their money in terms of just your work effort.
Thanks, Joel.
Yeah. And I can't see if there's other questions, but but I just wanted to add, just sort of looking in the rearview mirror of our project work with AIDS United. We did do a full report. We did prepare a full report on a lot of these contracting dynamics, and I'm pretty sure that's on AIDS United's website at this point, available to all at any time, at your own convenience to peruse a lot of that. But a lot of this slide content is conveyed in further detail in the 50-ish page report that's on the website also. I just want to make sure you guys know that's available. And I think the spreadsheet tool is available too, right, Mo?
Yeah, so all of the spreadsheets and tools that are mentioned throughout that paper are also located on AIDS United's website. And so that hyperlink that I put in the presentation actually takes you to the site that houses all of those tools.
And just so folks know, if you go to ageunited.org and you go to resources and webinars, that is where you will find the entire monetization webinar series and all of the tools and the report that Joel and Mo mentioned. So everyone, we have a few more minutes here. If anyone has any additional questions for the presenters, I encourage you to write those in the bottom left chat box. I will say, just as a reminder to folks while we are waiting for any additional questions to come in, that the Minji's group is providing some technical assistance and individual coaching with folks who are interested in monetization and interested in what we're covering in this series. If you would like to be put into contact with Mo to learn more about this technical assistance, you can email st@ageunited.org, and I will be able to put you in touch with the Minji's group. And this technical assistance is free to all HIV-focused community-based organizations.
If the questioner earlier in this webinar was Rafael from Puerto Rico, I just wanted to say we owe you a set of bullets, and we know we do, and I apologize for the delay, but we're very excited to try to go back and forth with you if this is you to sort out how you can get connected to some of the Puerto Rico payer entities as we discussed on the call. But there's we're at the point, Zach, where we've had initial calls with 5 or so entities. Mo, you probably have the exact number, but we're thrilled to just get invited to try to help, and we're far from declaring that we will help, but we're certainly going to try to help all of you that do enlist that, and it is a free service in terms of you guys won't be paying anything for it that asks for the help. So, but the opportunity to just engage in that way, we really appreciate and welcome.
All right, we will give it just about 1 more minute to see if any additional questions come in, and if not, we can wrap this up a little earlier than planned. And any questions that maybe come to you later or that you didn't feel like discussing with the entire group, I encourage you to email me at st@ageunited.org, and I can put you in touch with the Minji's group who will be able to address those questions. So just, I guess, about 30 more seconds now for any questions that folks might have before we conclude today's webinar. Okay, well, we don't have any additional questions, so I want to thank Joel and Mo for taking the time to go through this presentation today. Thank you to everyone who joined us for today's webinar, and please reach out by email if you would like to be put in touch with the Minges group for any questions or to take advantage of the technical assistance that Age United is offering with the Minges group. Thanks, everyone. Have a great rest of your day.
Thank you, everyone.